Y- Yes, we're doing some testing, and I'm hoping my voice is coming across okay. And it seems like you're my lifeline because when you were on mute, I couldn't hear anything. I hear you. Okay, and I'll be able to hear everything that's going on. Very good. Thank you. I'm going to go to mute.
With you, you can just say, that's why we test. Go ahead and
Testing, testing, testing.
love it. Okay, and then in a moment, we're gonna do, go ahead, please.
Testing, one, two, three, testing. Don't hear it yet.
One more time.
Testing, testing, one, two, three, four, out. Good.
Lastly,
Testing, testing. One, two, three.
one more time.
Testing, testing. Okay.
Okay. So go ahead and assume that you are live for the duration of the hour, but I'll do my best to mute you when you're not speaking at all.
Okay.
We're gonna start with introductions.
Okay, good morning, everyone. Did you want to say anything first to start? Okay. Just introduce me. Yeah.
So we're just,
You can come on into the center, you know?
Way over there.
Nobody wants to move. Okay.
Welcome to today's Hinckley Forum. My name is Rory Stewart. The Hinckley Institute of Politics is a nonpartisan institute at the University of Utah. The Hinckley provides an array of transformative experiences for students through internships, forums, and classes. Hinckley Forums seek to foster public discourse and civil debate on the most current and pressing issues, bringing in local, national, and international thought leaders. Today's forum is titled Global Health in Action, Case Studies on U.S. Interventions in the Area of Global Health, and is presented as the American College of National Security Leaders Spring Seminar here at the University of Utah. This panel will discuss lessons learned from personal experiences in global health interventions such as PEPFAR and Ebola epidemic in West Africa and immunization efforts in Guatemala. We are in for a great conversation. I'll first introduce our moderator, and then he'll introduce the rest of the speakers today. So our moderator is Ambassador Donald E. Booth. He was appointed U.S. Special Envoy to Sudan and South Sudan on August 28, 2013. Prior to his appointment, he served as Ambassador Extraordinary and Plenipotentiary of the United States of America to the Federal Democratic Republic of Ethiopia. Ambassador Booth, a member of the Senior Foreign Service, previously served as ambassador to the Republic of Zambia from 2008 to 2010 and ambassador to the Republic of Liberia from 2005 to 2008. Prior to that, he was the director of the Office of Technical and Specialized Agencies at the Department of the States Bureau of International Organization Affairs. Ambassador Booth has also served as director of the Office of West African Affairs, deputy director of the Office of Southern African Affairs, economic counselor in Athens, and division chief for bilateral trade affairs at the Department of State. He has also attended the National War College and served as a desk officer at the Office of Egyptian Affairs and the Office of East African Affairs. Ambassador Booth was also stationed at embassies in Bucharest, Brussels, and Libreville. So we'll pass it over to Ambassador Booth to get us started.
Great. Thank you very much. Good morning, everyone. Welcome. This is the first panel of the ACNSL University of Utah Spring Seminar. The theme is Global Health in Action. And we have a great panel of experienced practitioners with you this morning, former senior U.S. military and civilian officials who've led U.S. government responses to health emergencies overseas that posed a threat to Americans here at home as well as abroad. We'll hear about PEPFAR, the President's Emergency Plan for AIDS Relief, the U.S. government's primary response to the global HIV/AIDS epidemic. It's credited with saving over 26 million lives and dramatically reducing the level of infection of HIV and the mortality rates from AIDS. We'll also see how our response to global health threats is being affected by the elimination of USAID, budget cuts, and the new approach to global health programming being pursued under the current administration. We'll hear about the 2006 H1N1 bird flu outbreak in Africa that threatened to spread globally. In particular, we'll hear about the role of the U.S. military played in containing that outbreak. And if you think bird flu isn't important, if you remember a year ago how the price of eggs was a leading inflation indicator because of bird flu. We'll hear about the role the U.S. military played in responding to the deadly Ebola outbreak in West Africa in 2014. And time permitting, we'll hear about how one U.S. NGO, the Carter Center, has been our forward defense in addressing neglected tropical diseases that undermine development and stability globally. So it's my pleasure to introduce our panelists. We have two here in person and one virtually online, you can see on the screen. Tom Stahl, to my right, is a retired senior USAID official. He served in Sudan, several places in the Horn of Africa, the West Bank and Gaza, and Iraq. He was mission director in Ethiopia and USAID mission director in Iraq. Served as deputy assistant administrator for humanitarian affairs at USAID in Washington. And his final position in USAID was that of counselor, which is, I guess, the number 3 position in the organization. General and Ambassador Scott Gratian started in the Air Force as a fighter pilot and rose to be Assistant Deputy Undersecretary of Defense for International Affairs. And after retiring from the Air Force, he served as a special assistant to President Obama, was my predecessor as special envoy for Sudan, and served also as ambassador to Kenya. And online we have General Dean Sienko. He's both a retired public health physician and Army Major General. As a reserve officer, he served in Operation Desert Storm, in Kosovo, and Operation Iraqi Freedom. On active duty, he was commander of the Army's Public Health Command. He was most recently vice president for health programs at the Carter Center in Atlanta. So each panelist will speak for about 5 to 7 minutes, and then we'll get to the really important part of this program, which is addressing your questions. So with that, I will turn it over to Tom Stahl.
Thank you very much, Ambassador Booth. And it's great to be here with you all. Can you hear me? Okay, good. As Ambassador Booth mentioned, I spent most of my career with USAID. And so I'd like to talk a little bit about USAID, how we do health, and then kind of drill down using Ethiopia and PEPFAR HIV as an example. And then talk a little bit about the impact of the cuts to USAID and the new national health strategy. So USAID's approach to health is a very comprehensive approach. By comprehensive, I mean we look at the various interventions, prevention, treatment, and capacity building of the local organizations. And also comprehensive in that we work at the national level with the minister, with policy issues and so on, at the regional level where you have hospitals and health clinics and so on, and then all the way at the community level where you really have the outreach to the people. So it's comprehensive in that way. And then also in an integrated way. So it isn't that you're looking at individual health projects separately, but you look at how they work together and integrated with what a lot of other organizations are doing. There's UN organizations, there's other donors, NGOs, so you try to integrate things to have a greater impact. And the PEPFAR program specifically was a major effort. Health is the number one, the biggest individual project activity that USA did, especially in Africa. We also did education and agriculture and so on, but health was always the biggest. And PEPFAR was the biggest of those in terms of the funding and the outreach. Now, of course, individual countries had different rates of HIV prevalence. Ethiopia, even though it was a big program and it's a big country, over 100 million, their prevalence is quite low. Interestingly, I think it's because they have a strong cultural history of both within Christianity and Islam, and so you don't have a lot of extramarital affairs, shall we say. And so the prevalence is actually quite low in Ethiopia. In the rural areas, especially, it's very low. I mean, less than 0.5%. It was greater in the urban areas, but still even only about 3 to 4%. And then focused within that at university students, truck drivers, commercial sex workers, and so on. So in terms of our, program in PEPFAR, you want to focus where the problem is. So you work at it at the policy level with the government to figure out how to best, intervene and build up their capacity, both in terms of the clinical aspects and in terms of the actual outreach. Now, the program was implemented jointly between USAID and CDC. CDC focused more on the clinical aspects and the kind of the detailed medical aspects of it. That's their strength. USAID worked more at the community level and at the regional level in terms of the outreach to the people and so on. So it was a joint program. And it's, we worked very much on not only just the actual implementation of the program, but also the policy and the capacity building of the government and its various, regional and community thing to build their understanding of the need for it. They're figuring out how best to push the outreach and then the actual treatment. And we had major success, in terms of stopping the spread, in terms of helping people to understand the problem and what to do about it. A lot of times working even with the local churches and Muslim religious leaders, to understand the impact and the concern about how it can be affected by different aspects of how they live. And of course, had awareness campaigns and the actual treatment. Now, the treatment includes, of course, certain types of drugs, and that we would primarily get through what they call the Global Fund for HIV, tuberculosis, and malaria. And so USAID, part of our outreach was to provide funding for the Global Fund, who then purchased the drugs and brought them into the country. Then they were distributed to the government and to a lot of the non-government agencies that were implementing our program. And when I say non-government, some of them were UN agencies like UNICEF or other UN agencies, World Health Organization, but also both international and local NGOs, because a lot of the work that's being done, especially at the community level, was by local organizations, not just American international, but local Ethiopian organizations. The capacity of the government itself was limited in terms of their ability to work at the community level. A lot of villages didn't even have a health program. In fact, I think one of our most successful health interventions there, working with the ministry, was Ethiopia is a very rural country. And there were hundreds, maybe even thousands of villages that actually had no health facility whatsoever, as late as the late 90s into the early 2000s. Okay, and so we worked with the government to train and deploy about 36,000 young women to be community health workers in those villages that had no health facility whatsoever. And they could do a lot of real basic things, because the real problem was things like sanitation and obviously birth and death issues. They weren't even recording deaths up till then. And these young women could work in their communities with the local leaders and really make some huge impact. And we could then work our program of HIV prevention and treatment through those local communities and those local health workers. And that it was true not only in rural areas, but even in the urban areas. I remember President Bush came out while we were there to celebrate the 10th anniversary of PEPFAR. And we took him to a community right in the capital in Addis, families who were getting treatment for HIV. And it had a real impact that we were able to work at the community level as well as at the policy level and building capacity there. Now, you say, well, why don't we just, let the government do it, maybe provide them some funding? Well, all of our money for USAID came from Congress, 100%. We don't even accept other funding. And USAID felt very responsible to make sure that we monitor and account for all that funding, okay? We want to reduce fraud, waste, and abuse. In fact, USAID had a record of some of the lowest fraud, waste, and abuse of any agency in the government. And so that was part of the reason that we want to maintain that control rather than just letting the government do it. Now, we worked very closely with the government, but it wasn't just that we handed them checks. Like I said, we had a major, both in terms of building capacity, major success, but also in reducing the spread and then getting people's treatment. Of course, as you all know, with HIV, you don't just give them a vaccine or give them some pills and they get over it. It's got to be a lifetime thing. So that was a big part of the problem, was to make sure that people realize they have to keep coming back and get their drugs every month. And that's not easy in terms of their thinking. So, I mean, we can get into more detail in the Q&A, but let me talk just a little bit about the impact of the dismantling of USAID. Now, there was a very serious study done at the end of 2025, early 2026, to try to figure out the impact, okay, specifically on health and deaths. So a pretty solid and actually relatively conservative estimate was 700,000 people, women and children especially, have died because of the dismantling of USAID. And I wouldn't say the majority was PEPFAR or HIV, but a significant number were HIV. But that's across the board. A lot of them is, when a clinic closes, then a woman who's giving birth doesn't have anywhere to go, and she's doing it at home, and there are deaths there. Children dying of malnutrition, of very, treatable diseases, and so on. So it was huge, and things like pneumonia and TB and some of these things. So and the feeling is that it will compound. Okay, it's not that it will taper off. It's the opposite. As more and more people are not getting vaccinated, not getting treated, actually the number is going to grow over time. So it's a big issue. A lot of it's staffing shortages too, because a lot of these countries, the government doesn't have the budget to pay for everything. So without USAID and so on, and then the funding to UN agencies and so on. Now there is a new health policy. Some of you have seen the administration came out with a national health strategy, and they have actually signed agreements with 22 African countries on a new, what they call a health agreement, okay? And the idea is to provide funding directly to governments, okay, rather than working through local organizations or NGOs. And that has some benefit too. I mean, you want to build the government's capacity and so on, but the problem is, from our perspective, is that you're not building capacity, you're just giving them the money, okay? And there's a concern that a lot that, you don't just sort of have the money and then all of a sudden you can do it, okay? As well as you don't have the monitoring and the oversight as much about how they spend the money, and that's a concern. Now, one of the concerns that a number of African countries have raised, and in fact have actually suspended or not agreed to have the health agreements, is that the agreement calls for those countries that we're providing the funds to, that they have to provide all kinds of personal detail of all of the people who are receiving any sort of treatment, okay? Detailed, not only names and addresses and phone numbers and stuff, but health details, because the US would like to use those for research and trials and so on. But some of these countries are saying, hey, wait a minute, that's our private details of our citizens. We don't want to be providing that to another country, and we don't know and have no ability to control how they use that information. And then a couple of the agreements, Zambia, Zimbabwe, have concerns that the agreement calls for those countries to provide mineral resources to the US as a part of the agreement. So that's also a concern that a number of countries have raised. So we'll see how that works. I'm sure it's evolved. Part of the problem is that it's a template, and that's how they managed to do 22 agreements in a very short period of time. So it doesn't really allow for sort of flexibility and real detail. They weren't discussed with people in the country that they're working in. So there's, it needs to work. Anyway, I won't go into too much more detail, but we can talk about it more in the Q&A. So thank you very much.
Thank you, Tom. Scott, you want to head to the podium and...
Sure. Well, good morning, and thank you, Don, for that kind introduction. I'm really pleased to be here today. I've appreciated the Ute welcome and the hospitality that you've all shown to me. And I also really appreciate this sign and all the signs around this building. My wife's maternal name was Hinckley. So I feel like I'm at home with all these signs. It's wonderful to be here, and I feel like I'm with family. I'm not a healthcare professional. As Don said, I'm a fighter pilot, and that's really where I made my name. But I'll use the 1986 avian flu outbreak in Africa to highlight some lessons that we learned when EUCOM, the United States European Command, responded to this pandemic. I'll start with a quick overview, and then I'll briefly describe the military efforts in this pandemic, and finally I'll cover a few lessons that we learned, and then end up with some thoughts about the future. In 2004, the avian flu was detected in 8 Asian countries. A year later, migrating wild birds had spread this to Middle East and North Africa. And we saw pictures, shocking pictures of birds dying, and it caught the news headlines. And there was concern about the global health consequences, and there was concern about bird to human spread. And then in 2005, on September 30th, the UN said there's a possibility of 150 million people dying from this pandemic. Now, many of us didn't believe that those numbers were accurate, but in February of 2006, the flu was confirmed as a killer of thousands of birds at a commercial farm in Nigeria. And only 2 months later, that virus is causing massive losses in several countries across Africa. The growing fear of a continent-wide outbreak pushed health professionals, political leaders, and even military leaders started paying attention to the security consequences because this pandemic was real. It was serious. It was causing economic and health concerns that we hadn't experienced before. And in early 2006, a global coalition was formed with significant leadership from the United States. The alliance quickly deployed people and resources to help control the spread of the virus. But the task was overwhelming. Millions of infected birds were already dead, and millions more had to be culled to contain the virus. It was a huge economic disruption. To slow the spread, USAID personnel established quarantine areas, and they implemented culling programs and distributed vaccines. While these dedicated efforts of USAID personnel, together with those from the CDC, were absolutely critical, their efforts were insufficient, and we were failing to get in front of it. These organizations generally worked within the national borders of the countries where they were based. And because the disease was spread by migrating wild birds, we needed a regional focus, an effective cross-border operation with multiple governments working together simultaneously. And we were organized to work country by country. This is where the European Command made a significant contribution. We had built a communications network across the regional economic zones to help implement our security initiatives. So we now use this borderless approach in our regional communication system to synchronize the international efforts in the 5 economic regions. Our J5 task force was given the responsibility for the military piece, and we quickly researched the routes and the timing of these seasonal bird migrations. We identified the likely resting place near water sources, and our team worked with medical and agricultural professionals, in addition to USAID and CDC personnel, to determine the most effective ways to slow the poultry contamination on farms within these specified areas. We partnered with local experts to help them figure out the best methods to fight the avian flu. We also facilitated international support that helped with education, inoculations, and the culling efforts. By 2007, the number of countries affected by the flu decreased from a high of more than 65 countries to fewer than 7. The world could now breathe a collective sigh of relief. The lessons that we learned fell into 3 main categories. The first was detection and response. The second was multilateral cooperation. And the third was U.S. agency coordination. The first was detection and response. We learned that governments and health agencies must be constantly ready to detect, analyze, and respond to a global influenza threat. The rapid detection and the relatively swift coordination in 2005 were essential to limiting the bird flu outbreak. Detection and response must be a high priority to national planning exercises, budget submissions, and program evaluations. The second category is multilateral cooperation. Having the international community work closely with individuals in countries in Africa was critical for overall success. It's critical that international organizations like the UN assistant agencies, the African regional and security organizations, and applicable national ministries work together to routinely foster national and regional coordination protocols. We can and we must do better in this area. Finally, coordination between U.S. departments and agencies should be enhanced. While the U.S. assistance is generally administered as part of the U.S. Embassy's responsibility within a host country, we must think about using a regional approach when it's applicable to make assistance initiatives more effective. The Department of Defense has significant regional planning and coordination networks, and along with its logistics capabilities, it's a powerful tool, but sometimes gets relegated to doing war. I believe that the State Department and DoD should knit their planning and operational capabilities together closely with routine tabletop exercises and regular regional exercises with our partner. In conclusion, I ask, are we ready for the next pandemic? My answer is probably not. During the past year, we've watched as USAID and other outreach structures in our embassies have been underfunded and somewhat dismantled. In addition, I've observed that the traditional international assistance organizations have become somewhat streamlined and diminished. I believe that global challenges require international solutions and generally a regional approach to be effective. Given the current trend of strained global cooperation, the next variant of avian flu could be far more deadly than what we experienced in 2006. I believe it's time for the international community to relearn those 3 lessons and do more planning now for the next pandemic. Thank you very much.
Great. Thank you very much, Scott. Now we'll turn it over to you, Dean, for the final
thank you.
presentation.
I'm coming across okay?
You're coming across fine. Oh. Hold on.
Get him back on.
We have to get the screens back down. Okay, get you back on.
There he is. Okay, so he's back.
I think you're back. Yes,
I'm back?
you are, sir.
Back.
Okay, thank you. When I think about work in global public health, I have some broad categories that I think of. One is, are you going to do this on a full-time basis, on a temporary basis, on a part-time basis? There are a number of different options available. And then there's the sort of clinical arm of global public health, where you're actually on the ground doing clinical work, or the public health population-based work. So in the clinical sense, there are people that do this full time. They work with missionary groups. They can spend years providing broad spectrum care in villages or in other areas. Occasional clinical work could involve being part of a surgical team that goes overseas for 2 or 3 weeks and does, for example, cleft palate repair or some other things. In the military, we used to do something called MedReadies, which stands for Medical Readiness Training Exercises, where we'd send teams of military medical personnel to countries. I'm familiar with doing this quite a bit in Latin America. And these are designed to help our troops learn how to work in an austere environment, but they also strengthen partnerships with local nations, promote regional security, and foster goodwill. On the public health side, now you're dealing with kind of more broader, longer term, international, national objectives. So disease elimination, for example, and I'm going to talk a little bit later about what we did at the Carter Center with guinea worm. There are other things in terms of large scale interventions. We used to give what we called mass antibiotic administration, for example, to prevent an eye disease called trachoma. And so the whole community would get these medications, and it was very effective at diminishing the amount of trachoma, which is a blinding eye disease. And so public health work could include work in government, for non-governmental organizations, such as what I did when I was with the Carter Center, for foundations. For example, the Gates Foundation has done a lot of work in global health, in academia, and a variety of other areas. My first experience in global health was when I was working for CDC, and it was to investigate famine in sub-Saharan Africa that occurred in the 1980s. This famine was caused by severe drought as well as political instability. And in our case, the U.S. Agency for International Development asked CDC to send a team to measure the extent of famine in the country of Chad in order to help the U.S. government determine appropriate interventions. So our team traveled around Chad, and we did measurements of malnourished children and submitted a report to USAID, which I assume was used to determine appropriate amounts of food supplies and other humanitarian assistance. Years later, when the Ebola virus affected West Africa around 2014, I was the commanding general of the Army's Public Health Command. And there was global concern that this Ebola epidemic could get out of control and wreak havoc throughout the continent of Africa. The State Department was designated the lead U.S. agency for a response, and they wanted the Department of Defense to construct necessary health facilities. So many soldiers and other service members ultimately deployed to accomplish this. Well, the Pentagon called us at Public Health Command and said, what we want you to do is we want you to develop information for deploying service members about the risk of getting Ebola virus and how to prevent that once deployed to West Africa. So when you think about, what my familiarity with soldiers are, if they see somebody that got in a car accident and there's blood all over, their instinct is to rush in and try to help. Well, you don't want to do that necessarily in an area where there's a bloodborne virus such as Ebola. So you need to have a good education regarding that. And on another front, CDC was responsible for doing a lot of the public health work. So even though we are Army Public Health Command, we had a specific role that we were responsible for. Finally, I'd like to talk about my role as Vice President of Health Programs at the Carter Center, where I played a role in the global eradication effort of guinea worm, which is a debilitating parasitic infection. And so maybe you can see this a little bit. This is my souvenir guinea worm warrior guinea worm vial that I was presented with. Unfortunately for guinea worm, there's no vaccine and there's no medication to prevent or treat the disease. Rather, it requires clean water systems, which don't exist in many parts of the world. So we had to design strategies to treat contaminated water systems and help people know what water sources were clean for consumption. And we did this alongside our host nation partners. And I really want to emphasize this. Nothing gets done without the cooperation of host nation partners. And I was really impressed by the relationship that the Carter Center had developed over many years. And I think President Carter played a big role in developing those relationships. So not only did we depend on our host nation partners for practical advice about how to effectively engage in interventions, but we also needed their help for security purposes. Many of the areas of the world where guinea worm still exists, Chad, South Sudan, Mali, are areas where there is much domestic instability. At times, it could be dangerous work, and our local partners would advise us if we should not be in certain areas at certain times. These political instabilities are also hampering the eradication of polio. Cases of wild polio still exist only in 2 countries, Afghanistan and Pakistan. And arguably, until this instability is addressed, polio eradication won't materialize. And if you talk to people about eradication of diseases, the two that come up are polio and guinea worm. The only disease to date, human disease, that's been eradicated is smallpox. Now, there was a vaccine to address smallpox, and globally we eradicated smallpox from the planet in the late 70s, early 80s. As I mentioned again, with guinea worm, there was no vaccine, no medication. Yet, through public health intervention, we reduced the number of guinea worm cases from an estimated 3+ million in the early 1990s annually to now less than a dozen or so cases per year. So in summary, I just say that I really had a wonderful career in the global health work that I did. I enjoyed it professionally and personally. I found it extremely stimulating. And I look forward to engaging further with all of you on any questions or comments you have about this. Thank you.
Great. Thank you very much, Dean. Well, now we're to the important part of the program, which is your questions. You're all here presumably because you have an interest in potentially a career field in public health, whether domestically or internationally. So you've heard a couple of examples of where people from various backgrounds have dealt with various public health threats internationally as well as to the U.S. So open the floor to questions. Yes, please. Is there a microphone?
Hi, my name's Emma. I'm a political science senior here. Um, Healthcare disproportionately affects women. Women are often on the front lines of healthcare reactions, both privately in the home and professionally in hospitals. How do you all think that the dismantling of USAID will disproportionately affect women's role in society and their ability to grow beyond caring for other humans?
Yeah. Tom, do you want to take that one?
Yeah, I guess so. Am I on?
You're on.
Good. Yeah, I totally agree with you that healthcare and the dismantling of USAID is very possibly proportionately worse for women. And that's why we felt always that you had to have a comprehensive approach, because healthcare isn't just about, getting the drugs or things. It's about understanding your environment. So you need sanitation, you need to know how to take care of your child and your family and so on. So it was really about education, about health issues. And again, working through the local health community to really reach out directly to women was so critical. And that's why I'm worried about the approach where you're signing just a agreement with the government at the ministry level. Is it really getting down to the community, to the women, the community? It's a big concern. In fact, women, if you're doing development generally, you really need to focus on women, because in Africa, women do most of the farming, the agriculture, as well as healthcare, and even a lot of the sort of family finances. So many things, and you need to have a comprehensive approach. You can't just say, well, we're just going to do health without thinking about the broader impact of it. And I'm very concerned that that's going to be lost.
Yeah. Dean, did you hear the question?
Yes,
Okay.
I did.
Do you have anything you wanted to add on that?
Nothing to add.
Okay. Scott?
Yeah. When I was ambassador in Kenya, we looked at a program to reduce the number of excess deaths. And we found, exactly as you pointed out, if we could get the prevention mechanisms into women and children, we could significantly reduce the number of deaths. So we focused on maternal health, making sure that the women had the 4 antenatal visits. Working with USAID, we made sure that there was access to clinics and hospital, especially for those who are having preeclampsia and other issues that can be solved. But if you're giving birth in your village, they can't be solved. And just the cleanliness of how you cut the umbilical cord and all that. It's simple stuff, but it prevents death. And then when we started focusing on children with respiratory diseases, with gut problems and clean water, the prevention mechanisms that are available through USAID save tremendous amount of lives. And what I worry about is that without USAID education on prevention and those kinds of issues, that we're going to fall back into the traditional mechanisms of caring for children with diseases and caring for moms that don't have that medical oversight, and we're going to lose people. And my heart breaks, because I think we've taken tremendous steps backwards, and USAID, CDC, and other mechanisms, we're doing a tremendous job with the prevention process, which in my view is critical to saving lives.
I might just add that when I was in Liberia, stunting of youth was a huge problem. And you would travel around in the countryside and you would see the chickens scratching on the side of the road, totally malnourished chickens. And that was really the only source of protein that children could get. And yet the villagers wouldn't take any of their cassava, which was their main crop, to feed it to the chickens, because cassava is people food. Why would you feed your cassava to the chickens? The USAID director in Liberia at the time had actually done a master's thesis on this, and how if you fed the cassava to the chickens, you would increase obviously their body weight, and therefore the children would have more protein and stunting could be dramatically reduced. So again, dealing with the mothers to try to get that practice changed, because the men would just laugh at you. So yeah, it's just a minor, story about how focusing on women is so important. And the other thing that I think we found was that we did, besides health, a lot of U.S.'s foreign assistance went into the primary education area. And we found that actually the biggest benefits of that came from the education of girls. And so one of the key things of our water sanitation project was bringing restroom facilities to schools so that girls would be able to continue to attend. Other questions? Yes, please.
Hi, my name's Evelyn. I'm a sophomore here at the U. And I was wondering what role AI and data systems should play in early disease detection and response, and how you balance privacy and healthcare with these technologies.
Okay.
Okay, yeah, early detection is so important. Yeah, and again, it's not, you know, obviously you need to treat diseases, but as we've just been mentioning, prevention is actually even more important. And a lot of that is just basic stuff. You know, in Ethiopia, as an example, I mentioned these community health workers, and that was a big part of their role at the community level, was helping people, and especially women who are in charge of the health of their family, to understand basic things like sanitation. Part of their program was to have each family dig a pit latrine outside their hut. And that seems, you know, what does that matter? Well, you know, they were just defecating everywhere, okay, and nobody's washing their hands afterward. Okay, so even basic things like that have a huge impact on the health care of the family. Similar to what you were talking about, in Peru, I visited a village there, and they take care of, you know, guinea pigs is their main source of protein there. And they would feed the guinea pig and take care of them, and then change the baby's diaper, and then cook the meal, and they never wash their hands in any of that process. So basic things like washing hands has a huge impact on the health of the family and of the children. So some real basic prevention things are so important for improving the health of the family.
Let me just add that sometimes those basic things like washing hands, it's obviously the right answer.
Yes.
But if you're in a community where water has to be carried a mile from the stream, you know, on the woman's head in a jug, using that water to wash hands may not be considered the most effective use of it.
Yes.
You know, one of the things that I encountered in a trip to a very arid part of Ethiopia was we had an NGO working out there trying to get people to boil their water so that it would be safe to drink. To which I was in a setting, a community setting, and one of the women in the very back that the organizer never wanted to call on, and I kept saying, no, let her talk. And she said, "This is stupid. How can we boil water? Do you see any trees here? Where am I supposed to get wood to boil water?" So you have to think through the local circumstances as well, and try to come up with solutions that you know, are practical for solving the problem, not just kind of what we would normally think of. But you also had a part of your question about health data protection, I think.
Oh yeah, well I just remember you mentioning both of these new agreements, a bunch of countries not wanting to
Yeah.
participate because they were concerned about the citizens' privacy,
Yeah.
and also things like early detection systems. So
Yeah.
I'm just wondering how you balance like the use of technology and different data collection systems with patient privacy.
Yeah, that's a tough one. And interestingly, a lot of African countries are starting to understand how important that is. Again, that was part of our interventions, working at the policy level, that they need to collect the data, but then they need to protect it. And some countries like Kenya, for instance, most recently, has put in laws protecting that data privacy of health data. It needs to be used, and you know, you need to take advantage of it, but on the other hand, you also need to protect it. And in this world of modern technology where you can share this data, and that was a major reason why they decided to suspend the agreement that they had already signed with the U.S. For their healthcare, because the agreement said that they would share all that data with the U.S. So it's a sort of a rising thing. Previously a lot of that data wasn't even collected. In Ethiopia, they weren't even collecting death, indicators of, first of all, that people even died, and secondly, what they died of. Now, as a part of our intervention, they're doing that, but that also needs to be protected both for the people and for the country as a whole.
Dean, did you want to say anything about early detection or?
Yeah, I mean, early detection is really critical, particularly if you're thinking about epidemics, outbreaks. You want to get on top of them as soon as you can before they can get out of control. In terms, I can't speak for what's happening on the ground in certain countries, but it is important to receive the information. I mean, I don't need to know who it is who has a disease, but I need to know that there is a disease and how many cases and where they're located so we can deal with the problem. But what's happening on the ground in particular countries to protect those data, I can't speak to that, but certainly it's really critical to have good surveillance.
Can I just add one?
Yeah, please.
I think it's very important to protect data, but I don't like it when it gets in the way of things like electronic medical records and all those other things. I worked with an NGO where we tried to make sure that instead of having a little blue book that kept track of a woman's pregnancy, that it was put into an Android phone. The new technologies that are available across Africa are amazing. You've probably heard about M-Pesa, and 43% of disposable income is put into airtime in many nations. And I'm looking for the day when electronic medical records, where surveillance detection, where all this stuff is right there on a phone that we can issue to people. And QR codes can be put onto pins so we can get their data, we can get their name and address and whatever, so that when they have an emergency, their blood type is right there. The new technologies that are available across Africa are amazing, and we need to solve this interactive piece of medical privacy, but that should not slow down the proliferation of health records and health care assisted by AI and mobile phones, computers, and all that other stuff. I'm excited about the future because I think we're going to see us leapfrog into new technologies in Africa because they've skipped the traditional telephones. They've skipped the traditional brick and mortar, and we're going to an electronic base. And I'm excited about what healthcare opportunities there are to digitize all this stuff and make it more available to just the common workers.
Yeah.
And you can even put prescriptions on there. You can put reminders to get their antenatal stuff. I mean, there's so many things you can do to work prevention into this electronic database. And I think we need to be moving in that direction and don't get slowed down by the rules. Let's go.
General Wilmoth, you had a
I was going to make a comment. I
Just
was
a sec.
wait for the
mic.
microphone.
just so General Cianco can hear me.
Yeah, last name.
I was in Africa, in Kenya last year on a vacation, and we happened to visit a Maasai village, and there where the women were learning how to do beadwork as a way to make money, because if you put money in the women's pockets, the family prospers. But the most interesting thing was every woman in their traditional Maasai garb, as well as the elders, had their cell phones tucked into their Maasai attire. It was a very interesting juxtaposition of using their ancient beadwork, but yet they're all connected for banking purposes as well as other purposes. So what you're saying about the electronic availability, it's all over, even in tribal areas.
Right.
That it is a way to reach the people in a very different way that I wasn't expecting to see when I was there visiting. So it was a really interesting experience.
Thank you.
I think it really comes down to aggregate data versus individual information. And that's why we have HIPAA here in the US, to protect your own personal private medical information. And I think the issue of these new health agreements, where the US is demanding that individual level information be shared in order to receive funding. I think countries, if there's trust with us, would be willing to share more information than they're willing to sign an agreement right now because trust is a little bit strained, and frankly, they don't know how we're going to use it. So you have to build that trust over time. But we've had great information sharing agreements in the health area with countries for many, many years. It's just, how you approach it does matter. We have any other questions?
Sorry, we're out of time. We just hit the hour, so.
You didn't let any of the guys ask questions.
There will be a panel at 12 o'clock at noon, so there'll be more discussions. But let's give our panelists a round of applause. Thank you all for being here. Feel free to grab more food outside and stick around and chat with you guys.
Thank you.